Good afternoon. Thank you for joining this session. My name is Dr. Laura Kirui. I'm a hematologist at Aga Khan University Hospital, Nairobi, and I'll be presenting an abstract on the management of CLL in Richter's transformation. This was a multi-center phase 2 study carried out at the MD Anderson Cancer Center, the Dana-Farber Cancer Institute, and the Ohio State University. They were looking at the combination of Venetoclax plus dose-adjusted R-EPOCH for the management of Richter syndrome. Now, this is of clinical relevance because this is a group of patients who historically have a very poor outcome, and this is even in the era of the novel agents such as BTK inhibitors and BCL2 inhibitors, as shown in these two studies which were published in JCO. The study design had a primary endpoint of complete remission rate of Venetoclax plus dose-adjusted R-EPOCH for Richter's syndrome based on the end of combination therapy outcome using Lugano criteria, including PET CT scan. It had secondary endpoints of safety and toxicity of this regimen, rate of partial response measured by CLL MRD by flow cytometry, progression-free and overall survival, and the percentage of patients who were transplant eligible at the start of study who went on to receive a transplant. The statistical assumptions were as indicated, and the sample size was small with the aim of 20 evaluable patients. The eligibility criteria were as follows. Inclusion required confirmed diagnosis of CLL with biopsy-proven transformation to DLBCL, a good ECOG performance status of 2 or less, hematological parameters of absolute neutrophil count greater than 1 or platelets greater than 40, unless significant marrow involvement was demonstrated, adequate hepatic and renal function, and interestingly, patients with prior Venetoclax were still eligible. Exclusion criteria included histology other than DLBCL, prior therapy with R-EPOCH, recent allogeneic stem cell transplant, known CNS disease, and patients who were required to be on warfarin for anticoagulation. So the study protocol was, after screening, 1 cycle of R-EPOCH with recovery expected at approximately 3 weeks. On-count recovery accelerated a ramp-up of Venetoclax up to 400 milligrams at day 5, followed immediately by dose-adjusted R-EPOCH, the second cycle, with Venetoclax 400 milligrams 4 times daily on days 1 to 10, and then cycle 3 immediately afterwards, followed by a response evaluation. Patients could then go on to allogeneic stem cell transplant or Venetoclax maintenance if adequate response, or would proceed to 3 more cycles of dose-adjusted R-EPOCH with Venetoclax, and then end of combination therapy response evaluation with progression to a transplant or Venetoclax maintenance until disease progression or toxicity. These were the patient characteristics. Number recruited 26 patients with a median age of 63 years. CLL prognostic markers showed a large or significant number of patients with poor risk disease, including deletion 17p in 26%, TP53 mutation in 41%, and complex karyotype in 44%. The median baseline hematological parameters were as follows. Interestingly, the white cell count median baseline was 9 with a maximum of 32. Bulky lymphadenopathy of greater than 5 centimeters was noted in 56% of patients. Median number of prior lines of CLL therapy was 2, but ranging from 0 to 5. And these prior therapies included ibrutinib in 9 patients, venetoclax in 3, idelalisib in 2 patients, and duvelisib in 1. 6 patients were previously untreated altogether, and 17 patients were noted to be eligible for allogeneic stem cell transplant at study entry. The safety profile of this study showed grade 3 or more hematological toxicity in 50% of patients or above, most significantly neutropenia at grade 3 toxicity in 58%, and 54% had grade 4 toxicities. Non-hematological toxicity occurred in greater than 15% of patients, with febrile neutropenia being the most common in 38%. Infectious complications occurred as well. Notably, there was 1 fatality with sepsis during cycle 1 of R-EPOCH prior to initiation of venetoclax. And interestingly, no tumor lysis was observed in the accelerated ramp-up of venetoclax after cycle 1. Looking at how well the treatment was tolerated, dose adjustments occurred in 6 patients who required de-escalation of R-EPOCH to a lower dose. 1 patient was escalated to a higher dose level, and 4 patients had to have dose reduction of venetoclax. 10 out of the 26 entered patients died on study, 7 due to disease progression, including 3 who never received venetoclax. 1 patient had a sudden death, presumed to be cardiopulmonary. Another had fatal sepsis, as mentioned. A further patient died due to severe GVHD post-transplant. No deaths were attributed to the venetoclax R-EPOCH combination. Now, looking at the efficacy data, bearing in mind the primary and secondary endpoints, 20 patients managed to complete or take part in combination therapy and were evaluable for response. CR was achieved at end of combination therapy in 11 out of 20 patients, which was 55%. On intention to treat analysis, CR was achieved in 13 out of 26, which is 50%. All 11 patients who achieved CR had undetectable MRD assessment for CLL by flow cytometry. 2 patients with prior venetoclax who received combination therapy achieved a CR. 18 of the 17 patients who were eligible for transplant went on to undergo transplant in remission. And in follow-up, the longest patient post-transplant is now 2.5 years in complete remission, and the longest patient on venetoclax maintenance is now 2 years post-chemotherapy. 6 patients who were not able to be evaluated and did not receive combination therapy. 3 died during cycle 1 due to disease progression. 2 died during cycle 1 due to toxicity, and 1 patient withdrew consent in cycle 1. Now, this slide is just to show the experience of one 50-year-old male patient who had very poor risk cytogenetics and had been refractory to 2 prior lines of treatment, R-CHOP 2 cycles, followed by rituximab for 3 months, both with no response. This patient had a CT PET in January of 2019, which showed extensive hypermetabolic disease, which on biopsy confirmation showed Richter's syndrome. They were enrolled in the study and had clinical progression during the first cycle of R-EPOCH. They managed to initiate Venetoclax ramp up and then 2 cycles of Venetoclax plus dose-adjusted R-EPOCH, and at their end of cycle 3 evaluation were in CR. Unfortunately, they progressed off therapy while awaiting their transplant and died at 7 months with progressive disease despite attempted salvage treatment. And although this patient did have a poor outcome, it did show that in this patient with very poor risk disease, treatment response was able to be attained even with prior refractory disease to 2 lines of therapy, and therefore this shows that Venetoclax may be able to overcome resistance in combination with chemotherapy. Looking at the Kaplan Meier curves, we can see that the median progression-free survival was 16.3 months, similar to the median overall survival, and this is of interest in this group who historically have had a median survival of less than 1 year. In conclusion, what this abstract has presented was a CR rate of 50% by intention to treat analysis. This was even attained in patients who'd had some novel agents previously, including exposure to Venetoclax. About half of the patients who were eligible for allogeneic transplant were able to go on to receive transplant. And notably, cytopenias and infection occurred in up to 50% of patients, which is not entirely unexpected for a very aggressive regimen of treatment. Interestingly, tumor lysis was not observed in any of these patients, despite the aggressive Venetoclax ramp-up after cycle 1. And this is of interest, particularly as the last point has shown. Further studies are planned to look at the combination of Venetoclax plus R-CHOP, which is perhaps the more commonly used regimen in this patient group, and it would be of great interest. I will conclude there and again acknowledge the authors of this paper and their partners, and again noting this is of particular clinical interest because this patient group historically has not done very well on treatment, and this provides some hope, particularly in patients who are young and fit enough to proceed to allogeneic stem cell transplant. Thank you.